recording of arterial blood pressure. Now, arterial blood pressure, all of you know how to measure the arterial blood pressure. All the clinicians or the paramedical staffs, nursing staffs, even at patients at home also, they have purchased one blood pressure machine. So, all of them are measuring arterial blood pressure at home. But as a medical student or as a physician, you have to know the physiology of recording blood pressure. That's why I am mentioning this how to record the arterial blood pressure. Now, from the very beginning, what is pressure? Pressure is force per unit area. Per unit area. Force per unit area is the Now, our idea is to measure the total pressure or perfusion pressure of each and every subject. But to measure this total pressure or perfusion pressure, we have to measure it directly. Now, what is total pressure or lateral perfusion pressure? Perfusion pressure, when the left ventricle contracts, it generates some energy. That blood receives this energy from the ventricle into the aorta. As a result of this, blood moves forward. So, this perfusion pressure or total pressure is also known as the forward pressure. If the perfusion pressure is more, there will if the left ventricle contracts more energy will be received by the blood, more will be the perfusion pressure. If the left ventricle contracts less will be the perfusion pressure and blood will be less. But our idea of total pressure and perfusion pressure should be within a normal range. If the perfusion pressure is too high, then what will happen? There will be hemorrhagic manifestations and there will be cerebrovascular accident and patient might be goes to coma or patient might die. If the perfusion pressure is very less, because this perfusion pressure decides the perfusion pressure of different vital organs or all the organs of our body. If the perfusion pressure is very less, suppose in the kidney, if renal arterial perfusion pressure is less, it will lead to anuria and ultimately it will lead to death. For this reason, the perfusion pressure is very important. It decides the perfusion pressure of all the vital organs and all the organs of our body. So our idea to measure the blood pressure is to measure the perfusion pressure or total pressure. But to measure this perfusion pressure or total pressure, we have to measure it by a direct method. What is that? You have to cannulate one big sized artery and that cannula has to be fitted with the artery manometer and the artery manometer reflects the total pressure or perfusion pressure. Then we will get the exact value of the total pressure or perfusion pressure if we directly cannulate one big sized artery and the cannula has been connected with the artery manometer, then we get the total pressure. But routinely, to measure the blood pressure in each and every patient, or the clinicians or the paramedical staff or nurse, it is not possible to cannulate the big size artery because what will happen? Then there will be so many chances of infections, air embolism, thrombosis, etc. So routinely to cannulate any big size artery, then measuring the blood pressure totally impractical. So we cannot measure this total pressure or the perfusion pressure by direct method. Now what we will do? We will measure all the clinicians or all the paramedics or all the patients at home also. They are measuring lateral pressure by indirect method. This is by indirect. Now why am I measuring lateral pressure? How it helps? According to Bernoulli's theorem, total pressure is equal to lateral pressure plus half rho V square. That means if the rho is the density of blood and V is the velocity of blood. If the rho in density of blood and V velocity of blood remains constant, then total pressure and lateral pressure more or less close to each other. From this theorem, if we measure the lateral pressure, if we measure this lateral pressure, we are giving an idea of this total pressure. So lateral from this lateral pressure, we are measuring the we are getting an idea of the total pressure. So lateral pressure should be within a normal range. Now we cannot measure this total pressure by direct method. So what will we measure? We measure the lateral pressure. Now what is lateral pressure? Lateral pressure, suppose this is the blood vessel. This is a flowing column of blood. Lateral pressure. Lateral pressure is the pressure exerted by the flowing column of blood perpendicularly on the wall of the vessels while flowing through. Lateral pressure is the pressure exerted by the flowing column of blood perpendicularly on the wall of the vessels is called lateral pressure. So, perpendicularly on the wall of the vessel, like flowing column of blood giving a pressure in the walls of the vessels. So, we will measure lateral pressure. Now, how we will measure that? I will mention later on. This is lateral pressure. So, under the heading of lateral pressure, we have to measure. So, lateral pressure is the pressure given by the flowing given by the flowing column of blood perpendicularly on the wall of the vessels is the lateral pressure. Under the heading of lateral pressure, we have to measure systolic blood pressure. It is the highest pressure recorded in a cardiac cycle. While measuring the blood pressure, there will be so many cardiac cycles because cardiac cycles is coming in after every 0.8 seconds. But the highest pressure recorded in that cycle throughout measuring will be the SBP, systolic blood pressure. Now, diastolic blood pressure is the lowest pressure recorded in the cardiac cycle. There will be so many cardiac cycles, but the lowest pressure recorded will be the diastolic blood pressure. Now, pulse pressure. Pulse pressure is the difference between the SBP and BP. Mean arterial blood pressure. Here it is BBP plus 1/3 of pulse pressure. Here we cannot take the average mean of SBP and DBP divided by 2 because the systole is timing of systole and diastole is different. So we cannot take the average mean of SBP plus DBP divided by 2. So we have to take mean arterial blood pressure as DBP plus 1/3 of pulse pressure. These are the definitions we have to keep in mind and it will be asked during exam. Now casual blood pressure. If we record the blood pressure means lateral pressure. Casual blood pressure, any given instance you can record the blood pressure of the subject, that is casual blood pressure. Now basal blood pressure. Basal blood pressure is the pressure recorded under basal conditions. That is, if you can prepare the subject 14 hours after last meal, complete physical and mental rest, and ambient room temperature of 25 degrees centigrade. Then, if you can prepare the subject in a basal condition, then you are measuring BP. That is called basal blood pressure. So, all of the definitions you have to keep in mind. Now, what are the apparatus required? Apparatus required is the sphygmomanometer. This is the sphygmomanometer. This is the sphygmomanometer number 1. Apparatus required will be sphygmomanometer. Sphygmomanometer and strips. Sphygmomanometer. Sphygmo means pulse. Means pulse. Manos means thin. Meter is one measurement. So, sphygmomanometer was invented by Rossi. Then it was improvised by von Recklinghausen. But we are using the sphygmomanometer of this type now, and there are different types of sphygmomanometer. I will come to these parts later on. Now, sphygmo means pulse, manos is thin, meter is measurement. That means while measuring the lateral pressure, what we will do, we will first thin out the artery or thin out the pulse. Then we measure the blood pressure. Thinning out the pulse, then we first thinning out the pulse, then we measure the blood pressure. This is the this is called sphygmomanometer. Now stethoscope was invented in 1819 by Lemon. Now parts of the sphygmomanometer and then this stethoscope. First coming to the sphygmomanometer. See, the manometer has got two limbs always. It has got a long limb and this long tube graduated against a graduated scale from 0 to 300. See, 0 to 300. And this short limb acts as a mercury reservoir. Now, from the short limb, one tube is coming and this is attached with a cup. This is called Rivarossi cup. See this rubber bag inside. See this rubber bag inside. Now, it is enclosed in a cloth and this rubber bag is up to this. You can palpate it and feel it. Rubber bag is up to this. This is rubber bag enclosed in a cloth with a velcro. And this is connected with the short limb of the mitral manometer. From here another tube is going. This is called hand pump and inflation deflation screw. With the left hand, thumb and index finger, you have to practice this inflation deflation screw. This is the hand pump. With the hand pump, there is a hole is there. Through this, atmospheric air will enter into this. Via this, we will inflate this rubber bag. Through this, from the environment, we will take the air. So this Rivarossi cup is up to this. Now Rivarossi cup, sphygmomanometer. First is manometer. 0 to 300 millimeter. 0 to each division 2 millimeter apart. So it is a manometer is 0 to 300 millimeter. The long limb against a graduated scale. That scale against this graduated scale, the scale is 0 to 300 millimeter, and each division is 2 millimeter apart. So the lower limb of the mercury will be against the graduation. So always mention the result in even number, not in odd number. Because it is 2 millimeter apart, so always mention the graduations are 2 millimeter apart. So always mention your reading in even number, not in odd number. If you mention it odd number, examiner will know that you haven't seen the graduated scale. This is the manometer and the long arm of the manometer. The short arm acts as marker reservoir. From this short arm, one tube is coming to the this cup with this rubber bag. This rubber bag is known as the Rivarossi cup. Rivarossi cup. This is the rubber bag. This rubber bag, diameter and length of the diameter. This is very important. This is the weight of the cup. If it is the width of the cup is A, if the width is A, this is A plus A. Length will be A plus A. But this is only for this part. This is A, this portion is A, and this portion is A plus A. This Rivarossi cup. Now the Rivarossi cup is very important because we are obliterating any artery through this Rivarossi cup. Now Rivarossi cup, how to tie this cup? See how to tie this cup. First, I am just mentioning the principle. That's why I am showing you. You have to I will mention later on how to tie the cup. First, you have to take the two tubes on both sides of the brachial artery. Then do it like this. Now, everything I will mention later on. First, see, what I am doing. I am inflating the rubber bag. So I am inflating the rubber bag. The rubber bag through which portion? Through this big. Through this. Yeah, that means I am inflating the rubber bag. I am pressing the hand pump. So air is entering within the rubber bag. And that rubber bag is full of air. First, there is no air, now it is full of air. Now, air pressure, here is the brachial artery. We are measuring the blood pressure of the suppose brachial artery. So, the width of the cup is placing over the brachial artery. Now, the width of the cup, how the pressure is transmitted? Pressure is transmitted like a pressure cone. Our idea is to sufficient segment of the artery should be included within that pressure cone. Sufficient segment of the artery should be, this is called pressure cone. Sufficient segment of the artery should be included within that pressure cone. Now, when we deflate it, deflation should be very slowly. Deflation should be at the rate of 2 to 3 millimeter per second. Because of the inertia of the mercury is so high, you deflate it gradually, quickly, then what will happen? Mercury will not match with the falling inertia of the mercury. So mercury has a high inertia. So the width is important because we are measuring the blood pressure through the width. That means width of the artery. This width is important because width is passing over the brachial artery. This brachial artery, a segment of the artery, pressure is transmitted by I have mentioned that with the pressure cone. This pressure cone. This is pressure cone. And sufficient segment of the artery should be included within that pressure cone. So the width of the cup is very important. I am mentioning everything because it is why the width of the cup is important, not the length of the cup is important. Now the width of the cup is different in different age groups. Width of the cup is different in different age groups. Width of the cup is different in different age groups. Adult. Width of the cup is A is equal to 12.5 centimeters. Below 1 year, infant. 2.5 centimeters. Up to 4 years, 5 centimeters. Up to 8 years, 8 centimeters. Then adult, it is 12.5 centimeters. But in case of adult thigh, if you measure the blood pressure of the popliteal artery, in that case there is so much of tissue graft is here. Here is the cup and here is the artery. So much of tissue graft is here. For this reason, the adult thigh cup size is that is difference cup, adult thigh cup size is that is all is A. A. That is width. That is width. It is 18 centimeters. Adult thigh cup size is 18 centimeters. So adult arm cup size, arm cup size is A is 12.5 centimeters. So this is adult arm cup size. In case of thigh, it is 18 centimeters. It should be 18 centimeters. Like this. So the cup size is different in different age groups. You have seen. Why this is important? Cup size is different in different age groups. You have to keep in mind that cup size are different. Suppose you are posted in a health center, there is no adult children's cup size. So you have to bend it like this, hold it like this, and then you have to measure it. Because width of the cup is important. Now, why this cup size is so important? Suppose in children, 8 years old, 8 years old, because it's very thin, or this is not like adult, but on circumference should be at least 20%. The width of the cup should be 20% of the arm circumference. Now it is thin. In that case, if you have measured the blood pressure or 4 years of age, 4 years of age, if you measure the blood pressure of the subject with the adult, this is adult 12.5, with is 12.5. Now here, this is the next artery. The subject, the 4 years child, is suffering from nephritis. The subject is must having hypertension. If the subject is having hypertension, then what will happen? Now you are measuring the blood pressure with the help of adult arm pulses. But pressure is transmitted like pressure. So if you raise the blood pressure within the cup, within the cup, like this, it shall go immediately obliterate the artery. So less reading will be there recorded. Now, because and while deflating it, more and more you have to deflate. More and more and more and more you have to deflate. So that the pressure goes above so that blood can go like this. So what will happen? False low reading, false low reading will be recorded in case of the subject having hypertension. Subject is having acute nephritis. So what will happen? False low reading will be recorded. Now in case of popliteal artery, you have to make the subject prone. You have to make the subject prone. Then you have to grab the thigh. Now with the help of this ring, 12.5 centimeter adult cup size, arm cup size, popliteal artery is over here. You are measuring, trying to measuring the. This is the popliteal artery. You are trying to measuring the blood pressure of the popliteal artery. So what will happen? You are raising the blood pressure, raising. It is not obliterated. Blood pressure, it is not obliterated. Artery is not, blood is flowing. So we are raising. It is not obliterated. Coming over here. Or it might, if it is obliterated down here, it is not totally obliterated. And if it is obliterated at all if it is obliterated, then what if, at all if it is obliterated, what will happen? Then as soon as you deflate it, it will automatically go up. Very quickly it will go up. So false high reading will be recorded. I think you have understood my problem, what I have wanted to tell you. Why the cup size is very important in case of in different age groups, cups or in high or in arm. Why the cup size is so important, I have mentioned already. So you have to remember, keep in mind the cup size in below infant 1 centimeter, 4 to the 4, 5 centimeter up to the age of 8 years, 8 centimeter. Then adult 12.5 centimeter. Then in case of thigh, it is adult thigh, it is 18 centimeter. This is the abdominal sphygmomanometer. Now, what is the principle of sphygmomanometer? Now, I am coming to the principle. Principle of sphygmomanometer. First, what we have, suppose you have wrapped the cup. This is the adult arm size cup. There is something here is there. So deflate the screw and make it airless first, like this. We make it airless and tie the cup. How to tie the cup? I will mention later on. We have tied the cup. Then, after tying the cup, we are raising the blood pressure, air pressure within the cup. We are raising the air pressure within the cup. As soon as the air pressure will be more than the systolic blood pressure of brachial artery. Air pressure within the cup is more than the brachial artery, the systolic blood pressure of the brachial artery, no blood will flow to the. This is suppose this is the artery. This is the artery, and bag is around here. Then what will happen? You are raising the air pressure gradually. So gradually it is thinning out. Gradually it is thinning out. Ultimately it is totally like this. So no blood will flow to the brain. When air pressure is more than the systolic blood pressure of the brain. So first, in our body, the blood flow is a silent flow. Silent flow, normal streamline flow is a silent flow. If this is a streamline flow, so there is no noise will be there. It's a silent flow. But when we are constricting the or we are giving the pressure to the air pressure to the reverse cup, it will be get constricted. Ultimately, total stoppage of the flowing of the blood to the brachial artery, total stoppage of the blood to the brachial artery. Because air pressure is more than the systolic blood pressure of the reverse cup. Now, we after some time when we see first we feel the pulse. First we feel the pulse like this. Feel the pulse. When we see there is no pulse is coming, that means the artery is totally obliterated. Artery is totally obliterated. So we will try to deflate it. We will deflate it at a rate of 2 to 3 millimeter per second. We will deflate it at a rate of deflation rate 2 to 3 millimeter per second to match the inertia of the artery. Now we are deflating it. So what will happen? First it is like this. Now the artery has become like this. Now the brachial artery is like this. Because the air pressure is more than the systolic pressure. But we are deflating it. As soon as the air pressure within the reverse cup and the systolic blood pressure will become same. Air pressure same as SBP. Then it will slightly open. It will slightly open. And immediately, see the diameter is so less. So the velocity of the blood will be more. You know the Reynolds number, rho dV by N, Reynolds number, the critical value. If it is more than 2000, then there will be turbulence. Normal flow, I have already mentioned, this streamline flow is a silent flow. But there is turbulence will be there. So we will first auscultate one sound. we'll auscultate one sound just when the SVP and air pressure is same, just will open and as because the diameter is less, so blood will try to flow in a jet, and when the blood will try to flow in a jet, there will be turbulence. Reynolds number will be rho dV by N is more than 2000. Then what will happen? We will get one sound over here. That indicates SVP in auscultatory medium. And gradually it will change the diameter, gradually it will change the diameter. So if the gradually as soon as it will deflate it gradually, and when we take SVP here, it is the SVP here in auscultatory area, we will feel also the pulse of radial artery, up radial artery after few moments. That indicates SVP in pulmonary. That means when we are deflating it, as soon as the blood tries to go in a jet, we get a sound. That sound indicates SVP in auscultatory method. And you have to put one finger over the three fingers over the radial artery. As soon as you feel the pulse again, that it indicates the SVP in pulmonary. Now we are going on deflating it, deflating it, deflating. So diameter is gradually changing. So Reynolds number is gradually changing. For that reason, the sound character of the sounds is also gradually changing. For this reason, the character of the sounds is gradually changing, which auscultates different sounds. Those are known as Korotkov sounds. Russian scientist Korotkov sounds. And it you like double F like V or double F is Korotkov sounds. Now the sounds are first sound is the tap sound. Tap sound. The first sound. Here we will get the tap sound. Then the sound becomes like marmadishing character. So it will be second sound will be marmading. Marmading sound. Third sound will be first that is gonging sound. Then muffled sound. Then disappearance of the sound. So these are the 5 phases of the Korotkov sounds. You will be able to auscultate if you place the space or the stethoscope over here. Tap sound, marmading sound, and difference of this between almost 10 to 12 or 10 to 15. Difference of each sound. Tap sound, marmading sound, gonging sound, muffled disappearance. Now, this tap sound indicates systolic blood pressure, systolic SBP of the subject, and this disappearance indicates diastolic blood pressure in that subject. But in old age, this disappear comes very late. So at that time, we will do muffled plus disappearance divided by 2 will be the diastolic blood pressure of the subject. In that case, in very old age, muffled plus disappearance divided by 2 will be the DBP in that subject. Now this is the principle of sphygmomanometer. Now, I'm going to the stethoscope. I haven't taught you the stethoscope. Stethoscope was discovered by Bennett in 1819. 1819, it was discovered. And see, here the earpiece is there. Now tube, now chest piece with diaphragm and bell. How to hold the stethoscope is very important. It was discovered by Lennec in 1819. See, the earpiece should be directed downwards, forwards, and laterally. Here it is directed downwards, backwards, and laterally. So, correct way is to hold it like this, downwards, forwards, and laterally. Don't think about all these things. According to the direction of our external artery meters, so it fits into the external artery meters properly. Now it is tube, and this is chest piece or diaphragm, and this is bell. With the help of chest piece or diaphragm, we will auscultate high pitched sound. With the help of this bell, we will auscultate low pitched sound in case of mitral stenosis like that. So, what is if you want to do this thing, what you have to do? You have to move it like this. Then you suppose you are trying to auscultate the heart sounds or the auscultate the blood pressure. Now after putting it into the ear, you first see whether there is sound or not. If the sound is not there, you do it like this. That means this side is open. So you have to first do it like this and see whether it is coming or not. This is the principle of sphygmomanometry, and these are the apparatus, two apparatus only required. Now what will be the position of the patient? Position of the patient. Position of the patient is ideal position is the supine position. It may be we may be perform measuring of blood pressure in sitting position, but never in standing position. Always better to perform in supine position. In supine position, what happens? Why I am mentioning it should be at the supine position? Because by already sitting position, because the cuff should be at the level of the heart. This cuff, everlasting cuff, should be at the level of the heart. Suppose the subject is like this, sitting position, in sitting position, and we are measuring the blood pressure of the popliteal artery. That means we are wrapping the cuff over the thigh. And what happens? Due to the effect of gravity, part centimeter, part centimeter, away from the heart, blood pressure will change by 0.77 millimeter of mercury. Part centimeter away from the heart, it will change. In case of lower extremity, it will increase. In lower extremity, above, that means away from the heart. Above the level of the heart, above the level of the heart, again part centimeter will decrease. Blood pressure will decrease. Away from the heart, lower extremities, blood pressure will increase. But here, sorry, it will decrease. Suppose the blood pressure of the subject is 120 SBP or mean arterial blood pressure, so something 93 like that. Then blood pressure per centimeter away from the heart, 0 per centimeter multiplied by 0.77 milliliter mercury, it will increase in case of above the level of the heart, it will decrease, and in case of lower extremity, it will increase. So, in case of level of the heart, it will decrease. So, you have one, it is mean arterial blood pressure 93 centimeter minus the centimeter multiplied by 77 millimeter mercury, it will decrease and it will increase in the lower extremity centimeter away from the heart multiplied by 0.77 millimeter mercury. For this reason, cup should be always at the level of the heart. Cup should be always at the level of the heart. Why? Because we are asking to eliminate the effect of gravity. To eliminate the effect of gravity, cup should be always at the level of the heart. Now, if the subject is in supine position, it can measure the blood pressure of the subject in supine position, then in thigh or in arm, sub, it is always at the level of the heart. In supine position, cup is always at the level of the heart in case of thigh also. But in sitting position, only we can measure it in sitting position only in the brachial artery, not the popliteal artery. Now, what is the position? This is the position of the patient. Position of the patient is in supine position or maybe in sitting position, never in standing position, but cup should be always at the level of the heart. And what is the position of the sphygmomanometer? Sphygmomanometer always should be at the level of the observer's eye, examiner's eye to avoid parallax error. You can place it over high up or below, never, no matter. But there will be parallax error. So to avoid the parallax error, instrument should be at the level of the observer's eye and cup always should be at the level of the heart. Now position of the patient, now position of the arm. Arm, if this patient is slightly sitting or maybe supine, slightly abducted, arm should be slightly abducted, forearm supinated, hand facing upwards. This is the position of the, and you can it is better in some books, it is better to measure the blood pressure of the subject in the left arm because the left brachial artery is the direct branch of the subclavian artery, which is the direct branch of the aorta. So it is better to measure in the left brachial artery. But you have to measure the blood pressure standing on the right hand side of the subject, whether you measure from left arm or right arm. Any arm you can measure it, but you have to do it standing on the right hand side of the subject, proper illumination, proper exposure of the subject. Now I will mention how to tie the cup. First, see, first you deflate it properly. Now, see, this portion is plain, so this should be in contact with the subject's arm, and this portion is a velcro, so this should be above, and these two portion should be on both sides of the brachial artery. Before placing this cup over the arm, first place you are hearing all the cup sounds over the brachial artery. So you have to feel the brachial artery first. Ask the subject to bend his elbow. Now, medial to that, you feel the brachial artery. So you have to place the chest piece of the stethoscope over the brachial artery. For this reason, you first hold it like this. Hold it like this, like this. Place it over there. Cup should be in front or on both sides of the brachial artery. Now, like this. Now, tightly, you pull it as far as possible. This is, see, this is 3 finger above the bend of elbow. Why this is 3 finger above the bend of elbow? That is 1.5 inch above the bend of elbow. 2 finger is 1 inch, 3 finger is 1.5 inch. To leave the space for chest piece of the stethoscope, you have to place the chest piece of the stethoscope over the brachial artery. You have already seen where is the brachial artery. You have to place it over the, and it not be too tight, too loose, just admitting one index finger. This is how to tie the cup, like this. Now first, I am going to the palpatory method. By indirect method, we will measure blood pressure of the subject, lateral pressure, diastolic and systolic both. First, we will measure it by palpatory method. Now what will you do? First palpatory method, we first feel the pulse. First in palpatory method, first feel the pulse. Then you raise it. Until and unless there is disappearance of the pulse. Until and unless there is now pulse has disappeared. Now I am deflating. Now to be on the safer side, to raise it more, 10 to 20 millimeter mercury more than disappearance. First note the disappearance of the pulse, then raise the air pressure or the mercury column 10 to 20 millimeter mercury more than that, because to be on the safer side, now deflate it gradually at the rate of 2 to 3 millimeter per second, where you will get the, again you will feel the pulse. Now I got it at the level of 110, 110 millimeter of mercury. So SBP in palpatory method will be 110 millimeter of mercury. See, I am holding it wrongly. I have to hold it like this. Now I am placing it over the brachial artery. Now, how much I will, how much pressure I will raise in the mercury column? Not just 200 or 240 like that. That you have got the rough idea of the systolic blood pressure and the brachial palpatory method. Palpatory method, it is 110, so we will raise it maximum 30 to 40 millimeter mercury more. So we will measure, we will raise the mercury column maximum 30 to 40 millimeter mercury more than the palpatory method. That is a measure maximum up to 150 to be on the safer side of myself as a doctor. Don't go more than the palpatory method, maximum 30 to 40, not more than that. Now, while deflating it, I have heard the different types of different sounds. That is the first color sounds. I have heard the taps and tap. Then I have heard the murmuring sound. Then gonging. Then muffled. Then disappears. So it has came at 115, sorry, 114 millimeter of mercury. I don't say odd number. 114 millimeter of mercury SVP, and arterial blood pressure is 74 millimeter of mercury of the subject. So now under palpatory method, we have measured the subject's SVP. What is the advantage of palpatory method and disadvantage of palpatory method? In palpatory method, in auscultatory method, we are measuring both SVP and DVP. But in palpatory method, we are measuring only palpatory SVP. So why you are going for palpatory method? But palpatory method is very important. Never forget to do the palpatory method first, followed by the auscultatory method. Because by palpatory method, we are getting first one rough idea of SVP. Rough idea of SVP. Here the SVP will come little bit earlier because just opening of the brachial artery there will get a blood, so we will get the first taps on. But sufficient blood has to come over here so that we can feel the pulse over the brachial artery. So there will be some gap will be there. There maximum 4 to 6 or 6 to 8 millimeter mercury more. 4 to 6 millimeter mercury. This is less than the auscultatory method. Maximum 4 to 6 or 8 or 60 millimeter mercury less than that. So we are getting first number or rough idea of SB of the subject. Then we are getting by palpatory method, we are avoiding the auscultatory gap. This is the most important thing. What is auscultatory gap? Auscultatory gap is any phase of the cortical sound may remain silent. That phase is known as the auscultatory gap. Suppose a patient in auscultatory gap happens in hypertensive patients, cause not known. In some hypertensive patients, what happens? If you do not do the palpatory method and go for the auscultatory method first, what happens? First, in auscultatory tap sound you may not be able to hear. It is not audible. Tap sound. And murmuring period remains silent. Then first gong will appear as tap. Then suppose a patient is of hypertension, you don't know the patient is having hypertension. It is 200 or 240 millimeter of mercury hypertension. SBP is that. But you have raised it up to 200. You have thought I have raised it more. 200. So you have missed that. Murmuring is silent. Now first gong appears 180. And you will think the patient is having 180 by 90 like that. So it is okay, and you have to prescribe some medicine. But as soon as you leave the room of the, you have, if you come to the patient's room house, leave the room, or as soon as the patient goes out of your clinic, the patient will vomit and become unconscious, and because of the huge hemorrhage, because you have missed the palpatory method. If I haven't done the palpatory method, so you have missed the first tap sound. If you do the palpatory method, if it is not 240, it will do 30 at least. So to be on the safer side, you will raise it 30 to 40 millimeter mercury more. Then you won't be able to miss the tap sound. You will miss the you will get the tap sound at least to 30 or to 20. You will get the tap sound and murmuring sound remains silent. Then it plays see how auscultate the gonging sound. Then murmuring and then. So this is the thing. Maximum in the all the coax, all the sisters and everybody. I don't blame anybody, but most of the doctors or many good people do not do the palpatory method. But palpatory method is safer for the doctor or paramedical staff or nursing staff herself or himself because it helps us to avoid the auscultatory gap and it gives us the rough idea of the systolic blood pressure. And the systolic blood pressure, if we auscultate over here, it will be 4 to 6 meter mercury more than the palpatory method I have mentioned. The sufficient blood has to come over here, then we will give the palpatory method, SBP in palpatory method. And here, if we auscultate the palpatory method over brachial artery and do the palpatory method over the brachial, both over the brachial artery, then both SBP will be same. But if we do over there, there is a gap of 4 to 6 meter. To raise up to this. Thank you.